If you're struggling with pelvic floor dysfunction issues, this episode of Ironing Out the Wrinkles is a must listen. I'm your host, Ros McMaster. We'll be discussing incontinence, constipation, defecatory difficulties, and pelvic pain, which are common pelvic floor issues that can be very distressing and often cause suffering and social isolation. These issues can affect individuals of all ages and genders. However, they're more common in adults over 65, with a prevalence rate of 20 to 50% in women and 5 to 25% in men over the age of 50. To help us answer questions about pelvic floor disorders, their causes and treatment options, Dr. Chris Gillespie, a specialist colorectal surgeon, joins us on today's episode. Dr. Gillespie has a special interest in functional issues with the bowel and practices at Mater Private Hospital in Brisbane. He has also set up a multidisciplinary service called the Queensland Pelvic Floor Centre in Bowen Hills, Brisbane, to provide care to people with troublesome bowel or pelvic floor issues. Dr. Chris Gillespie, hello and welcome.
Thanks, Ros, and thanks very much for having me. Great to be here.
Yeah, I was just saying before we hit the record button that I always wondered why people would get into this field, but after doing a little bit of research, it is fascinating.
It is. I mean, it is incredible how common pelvic floor disorders are. There's people who know about them, and then there's actually a huge amount of people out there who have some symptoms or some kind of trouble and don't realize that it's related to the pelvic floor. It's a fairly loose term, the pelvic floor. It sort of summarizes, I sort of describe it as the whole pelvis. It's a really important part of our body. And, overall, I think poorly understood. We understand it well, but in general, it's poorly understood. And a lot of people are suffering out there, and there are things that can be done to help these people.
Yeah.
The impairment in quality of life is massive.
Oh, yeah.
And it is nice when you can, I treat, all kinds of other things. I treat bowel cancer and serious life-threatening conditions and all that, and that's satisfying. But to be honest, I probably get more satisfaction out of treating someone who's suffered for years and years with terrible symptoms, and you're able to turn things around and make their life better. So it's actually satisfying to be a part of.
Oh, that's really good. Well, that brings us really a nice segue into my first question. As a colorectal surgeon, could you explain the intricate functions of the pelvic floor and its importance in the body's anatomy and physiology? Is it possible to make that not a huge question?
Yeah, no.
Like, how much time have we got?
Yeah, exactly. How many hours have you got? Oh, look, I mean, the way I'd probably summarize it. So pelvic floor is a loose term. I mean, really, when I talk about the pelvic floor, what I guess I sort of mean is the muscles that we have at the bottom of our pelvis. These muscles are really important, but they're only a part of the entire system. These muscles are really important, and they help to control the function of our bowel, the function of our bladder, and sexual function. And to make things simple, the way we were created was that each muscle actually affects all of the organs. So, for example, the muscle that opens your bowel is the same muscle that opens your bladder. But depending on what other muscles are doing, you might open your bowel or you might open your bladder. It's actually very difficult. I don't know if you've ever tried to open both your bowel and bladder at the same time. And that's because of the way that the muscles are set up. And so that's a part of the system. And those muscles are controlled really by our subconscious brain. Right now, your pelvic floor and my pelvic floor are active. There's muscles that are working that we don't have to think about. We've got too much else to think about in life than our pelvic floor. The way I describe it to patients is it's a bit like your breathing muscle. Your breathing muscle is working all the time. We don't have to think about it. It just works. Sometimes if you have, for example, severe anxiety and a panic attack, if you've ever had a panic attack, you'll know that your muscles start breathing out of control and you're trying to stop them and they can't. And your pelvic floor muscles are a little bit the same. They're really under subconscious control. There's constantly talk happening between that part of your body and your brain stem. in terms of sampling, in terms of preventing leakage, and hence severe anxiety and psychological distress can sometimes manifest in that part of our body. That's where our sexual organs are. We can go into protective mode, and we can protect ourselves when we have psychological distress. And then, of course, that goes into sexual abuse as well. We protect ourselves in that part of our body, and those muscles become hypertonic, trying to protect you. But at the same time, it can affect your ability to use your bowels and your ability to use your bladder. The rectum, if we want to talk about the rectum, the way I talk about the rectum as I say, the rectum is a reservoir for storing stool. It's the last part of your gastrointestinal tract. I say it's the most important part of your gastrointestinal tract. And the rectum, really, its job is to store stool. When it gets really full, it needs to tell you that you might need to start looking for a toilet. And if you're not near a toilet, we can hold on. That's a great thing to be able to do, of course. Importantly, it's also got to be able to empty, and it's got to be able to empty satisfactorily. When we go to the toilet, we actually don't just empty our rectum, we empty our rectum and about half of our large intestine in one go. There's this mass movement which occurs in the colon, where we push, usually once a day, we push all our stool right down into the last part of our rectum, and then mechanically our body is able to take what's inside us and put it outside us. And that's really a subconscious maneuver. We don't really know what we do when we go to the toilet. We sit in the toilet and something happens, and we don't really know how we learn to do it either. We don't sort of sit and stare at our parents on the toilet and learn that way. We just sort of pick it up in childhood in some way, and then we don't leak in between going to the toilet. And everyone takes these things for granted. We just think it's normal, and it's only when you can't do these things, or the functions don't work so well, that you start realizing what an amazing system we have. And the same with our bladder. Our bladder is able to empty fully. We're able to hold on if we need to, and we don't normally leak urine. Leakage is always abnormal. It is never normal to leak urine. It is never normal to leak stool. It's never normal to have to rush. It's normal to be able to hold on. And so, sometimes we sort of fight this myth that it's okay for a woman to leak urine later in life. It's actually abnormal. It's not normal to do that. And there are treatment options and ways we can try to improve the function. We can't always cure people. And I sometimes say to people, I'm not going to make you the best pooer in the world or best weir in the world. But if we can make your symptoms better so that you're not so bothered by this problem, because when people are bothered by these problems, it can be utterly devastating. It can affect every aspect of someone's life. If you're worried about having an accident in your underwear, or your bowels working without you being able to stop them, you're going to stop coming out. You're going to stop going and having that cup of coffee with your friends or with your family. It's going to affect your ability to work. It affects your relationships. You get marriage breakdown, even suicide,
Oh my goodness.
severe depression. So it is, people are highly, highly distressed when they have these problems. And that's why it's nice to be able to help them, because you can really, really impact someone's.
Really change lives.
You can.
Yeah. Well, that's really interesting. I think you've answered half a dozen questions just in that, but anyway, but that's nice to know. I really had no idea just how big an impact it had on people, or how bad it could be. I remember when I was a little girl, I was in the supermarket with my grandfather, and I looked down and he had wet his pants. And, as children do, I very loudly said, "Oh, Grandpa, what happened?" And, "Oh, I just broke a bottle in my pocket." And for some reason, I've never forgotten about that. But, as an adult, I look back and think how embarrassed he must have been by that.
Yeah.
So just
Embarrassment
terrible.
it's one of the things people talk about the most is embarrassment. And, there's nothing worse. And despite the problem actually being quite common, people just don't want to talk about it. A lot of people, they say to me, am I the only person with this? And I'm like, no, this is actually incredibly common. People feel like they're the only person in the world with these kind of problems. But it's incredibly common. Unfortunately, I mean, we see people of all ages. I see teenagers with these problems, people in their 20s, but we do see more elderly people, usually, as you say, above 50 or 60, and predominantly females. And the reason for that is that not the only, but one of the most common causes is obstetric trauma. So traumatic vaginal delivery. Of course, men don't have babies, so that they're excluded from that group. We absolutely do see men with these problems, but we see more females. So around about 80% of our patients are female, about 20% male, and we see females who haven't had babies as well, because there are other causes of pelvic floor dysfunction aside from obstetric trauma. So like I was talking about before, people who this complex and amazing ability to empty our bowels, it can be disrupted. So some people, they never quite learn how to poo properly, and they exert excessive pressure, and they strain and they strain, and they may not even be aware of it, because we don't all poo in front of each other. It's a very behavioral thing. It's incredibly behavioral. In fact, you get people who say, I just want to poo in my toilet at home, and they will avoid public toilets. They'll never ever go to a public toilet. They'll tell you a story about how they never use the toilets at school. It might have been because they were being bullied about it, or it might just be because they felt uncomfortable. And the classic story they'll always tell you is that they'll go away on school camp, and they'll go away for a week, and they just won't poo. They'll just hold on and cause all kinds of damage to themselves, and then just wait till they get home so they can use their own toilet. Our own idea of what's normal is not very accurate. I saw a lady recently, and she told me that she only pooed once a week, and she was about 25, and she said it wasn't until she got married and she saw her husband going to the toilet every day, and she said, what's wrong with you? Why are you going to the toilet so often? And he said, no, I'm the one who's normal, you're the one who's abnormal. And it was only then she realized she actually had a problem. So our own perception of how well we're doing things is not very accurate, and some people over years and years just exert all this pressure, strain, and then I see them 3 or 4 decades later, and they've done a huge amount of damage, stretched things out, and they end up with the same net result as obstetric trauma, which is a more rapid progression.
Yes, wow. Oh, that's fascinating. Well, we'll get more into each of those actually, because I've, got questions about how often is the normal amount, because you don't actually need to go every day either, do you? But let's start with, how does the pelvic floor actually change as we age?
Yep.
And we know that pelvic floor disorders are common occurrences with aging. But did I
Yeah,
get the
absolutely.
statistics right in the beginning there?
Yeah, no, they were very accurate, and that it's incredibly common. I guess, measuring this is actually quite difficult, because there are a lot of people out there who sort of think they're normal, but end up with a problem, and then they realize actually for a lot of the time they weren't quite normal. So I think we definitely grossly underestimate the prevalence of this problem. But to give you an idea, the fecal incontinence is one of the 3 most common reasons for an elderly person to be admitted to a rest home, a nursing home. So
Really?
yeah. So it just gives you an idea of the impact, because they just struggle to cope at home, and they end up in a nursing home just because of fecal incontinence. So, but as we age, I mean, the 2, if you look at pelvic organ prolapse really just means that the supportive connective tissue that holds all of our organs inside our pelvis has become stretched. And so when we walk around, in particular, when we push to go to the toilet, things move lower than they should. And sometimes things even start poking outside. So, we understand that with vaginal prolapse, where part of what's inside us ends up outside us. As a colorectal surgeon, I see the same thing with rectal prolapse, where our rectum, which is normally inside our anus, ends up outside the anus, and that may occur when someone's going to the toilet. It pops out and goes back in, or it may be that it pops out and even starts staying outside. And so the animals, if you look at the animal kingdom, basically the animals that end up getting this problem are bipeds, in other words, two-legged animals, so us and the apes. And the reason for that is that we spend a lot of time upright, so we've got gravity against us, so it's far more common in animals that are upright. And so really with time, and then loss of collagen, which is an age-related problem, and that's precipitated, of course, by menopause as well in females, and then gravity, and then over time just straining and straining and straining. So we strain when we go to the toilet, but we also strain when we lift up objects, when we do heavy work, and this is just cumulative over time. And over time, that stretching gets bigger and bigger and bigger. So, you might have someone who, for example, started off with some obstetric trauma in their 20s or in their 30s, but then there was no initial problem. But then over time, over decades later, activities of daily life, a bit of heavy work, a bit of straining, pushing a bit too hard, perhaps when they're on the toilet, leads to further prolapse, and that loss of supports leads to worse function. And the organs, which are trying to do their job, are just not able to do their job so well because they've lost their supports, and the mechanics, the beautiful mechanics that we have in our pelvis, are affected. And so hence it's more common in elderly people.
Oh, wow. Okay. So when you say heavy lifting too, all these people that are doing these heavy weights at the gym,
I'm
that's going
glad
to
you
have a
brought that up.
long-term effect.
Look,
Yeah.
it does. So there is a bit of a craze at the moment. If you look at the younger population and people going to the gym and getting more and more into lifting heavy weights, the things that I find that are particularly problematic are people who do a lot of squats and people who do a lot of deadlifts and are really just pushing themselves and aiming to lift heavier and heavier weights. Every time you do that, we talk about the abdominopelvic cylinder. So we've talked already about the pelvic floor, but defecation doesn't only occur in the pelvic floor. You use your paraspinal muscles, you use your oblique muscles, you use your rectus abdominis muscle, that's your six-pack muscle in your abdomen, and you use your diaphragm. It's an entire whole abdominal maneuver. When we lift weights, we essentially do the same thing. We contract our pelvic floor and we generate all this pressure. And over time, doing that can lead to a dysfunction of those muscles. So those pelvic floor muscles get really, really good at contracting because they're used to you lifting weights, but then they're not so good at letting go and allowing you to go to the toilet. So you can end up with dysfunction. But also just the sheer pressure itself can cause problems. I mean, I saw a young man a little while ago. He was about 20 and he wanted to be a professional rugby player. From the age of 12 or 13, he had gone to the gym. The guy could barely fit in the room because he was so big and so muscular, and really big guy. And he actually had full-blown rectal prolapse. So when he went to the toilet, his entire rectum came out of his anus. Debilitating condition, terrible for a young 20-year-old man to have. And in my opinion, this occurred from just doing so many weights and pushing so hard for so long. So exercise is very important. It's important for health. It's important for mental health. But I'm just specifically talking about overdoing it and really going crazy on the weights. It's not as benign as you might think.
Oh, well, I'll let my daughter know. She's 26 and she's a gym junkie, and her weight training on a daily basis has already caused so many bodily health issues for her,
Yes. Yeah.
with her bones,
Yeah.
periods, everything. So I will let her know.
Yeah, look, it's a balance, it's about life, it's about having a good life. It's not just about having a good pelvic floor. So, I say to people, go out, go for runs, go for bike rides, go to the gym if you want, but just maybe modify a little bit what you do. Maybe don't do the deadlifts and squats so much. And if you do, just modify the weights, go for higher reps and lower weights. So it's all about reducing that pressure during that, what we call Valsalva maneuver. It's just a part of the problem. Yeah.
Part of the problem, yeah. So the most prevalent types of pelvic floor dysfunction in older adults? I mean, you already mentioned briefly, it sounds like rectal dysfunction is the most prevalent by the sounds of that, but it
That's
depends.
probably,
In women, different to in men, I imagine.
yeah, look, I mean, that's probably my bias as a colorectal surgeon. Obviously, what I see is the bowel related problems. We have, as you said in your introduction, we set up this center, the Queensland Pelvic Floor Center, which is in Bowen Hills, and the model or the concept behind this is that what happened before is that patients were, if they had a bladder problem, they'll go and see this person. If they had a vaginal problem, they go and see this person. A bowel problem, they go and see this person. But actually all these things are related. These organs share the same supports. If you have vaginal prolapse, it's very likely you're going to have some kind of bowel problem and some kind of bladder problem, and vice versa. So probably, to be honest, the most common, if that's your question, the most common kind of pelvic floor complaint would probably be urinary incontinence, would be the most common, probably followed by vaginal prolapse. So I'd say they are probably more common than bowel symptoms, and then probably of the bowel symptoms, difficulties going to the toilet and consequent constipation is probably your next most common, followed by bowel control problems. But as I say, what's important to understand is that the majority of patients have a number of these complaints all at once. And that's why we set up this center, because you really need to holistically understand that and address the entire patient. And what we're trying to do is try to improve the care overall for patients in Australia, because we have at the moment a bit of a what we call uni-compartmental approach. And really, patients that we see who have a bladder problem, if you ask them about their bowels, you'll probably find they've got a bowel problem. They may have a bit of prolapse of their vagina as well. And the best treatment that they can have is to understand all of that and have a holistic, what we call multidisciplinary treatment.
Wow, I love that. That's really good. So how do we know we have a pelvic floor disorder? There's obviously some early warning signs, and we can tend to make excuses for them like anything else, which I know is how a lot of cancers don't get found until it's too late. You can always find an excuse for why a symptom happened. But yeah, early warning signs.
Yeah, look, basically, I guess understanding that these symptoms are not normal, because as I say, there's a lot of normalization that goes on. I mean, to be honest, if you see your GP and you said, look, sometimes I have a bit of trouble going to the toilet, probably quite a number of GPs may say to you, oh, that's normal. Or there's also a perception that there's not much that can be done about these problems, and that it's best to just put up with them, or that it's a normal part of aging or a normal part of motherhood as well. Being a mum, that's okay to leak urine when you bounce on the trampoline. It's not, these things are not normal, and there are things that can be done to improve them. So, I mean, if you go through them, leakage of urine, difficulties emptying your bladder, a dragging sensation or a bulge sensation in the vagina, or difficulties with intercourse, a pain or discomfort in the pelvic area or abdominal area. And in terms of bowels, difficulty emptying your bowels. So you might feel, look, I feel like I need to go to the toilet, but I just can't adequately empty, or I don't get much of an urge to go, or I occasionally rush or leak feces. There's a significant crossover with irritable bowel syndrome. And which I think is something that you were going to ask as well. And that, so people who don't empty their bowels properly will experience bloating, because their colon is not emptied, so it fills and remains filled with gas, and you have ongoing fermentation and creation of more gas. It's obviously full of feces as well, and as that pressure goes up, they may even experience pain in the abdomen as well, frequent pain, perhaps relieved if they're able to go to the toilet really well. But often these people have trouble going to the toilet well, which is the underlying problem. So all of these things are linked, and it's a matter of understanding that, and then finding a practitioner who's able to understand these problems and offer some kind of treatment. In particular with the bowel, you talked about things like cancer before. I mean, bowel cancer is common. and that's something people often don't quite appreciate, how common bowel cancer is. I mean, males in Australia have a 1 in 10 chance of getting bowel cancer, and females have a 1 in 13 chance of getting bowel cancer. And these things are common, and sometimes these cancer can present with some bleeding that you might think was hemorrhoids, or with some of these symptoms that I've referred to. So particularly if someone's never had a colonoscopy, if someone comes to us with these symptoms, we do need to think outside the square and think, could it be something further up in the bowel? And we do occasionally pick up, some of these more serious diagnoses, and that's important as well.
Yeah, that's the funny thing with the bowel, isn't it? And what I was saying before, it's, we can always find excuses for things that are happening sometimes, because if there's changes, it might coincide with, well, I didn't really eat as many vegetables this week, or because I know I was diagnosed with bowel cancer back in 2016, but
Oh, yeah.
I had no
Mhm.
idea. Like, I literally had decided to
Mhm.
go on this big health kick, and I was juicing every day. I went on this big juice detox. It was all I was having. So I
Mhm.
had no pain, no discomfort, no rectal bleeding, none of that.
Yeah,
But when
right.
my
Okay.
bowel motions changed, I went, oh, it's just because I'm juicing.
There you
No
go.
idea. No idea.
There
Yeah.
you go.
So,
So, a change in bowel habit alone is a potential indication for colonoscopy. I mean, you can have bowel cancer for quite some time and have no symptoms at all. I've recently, just in the last couple of weeks, treated a young man in his early 40s who he just experienced a bit of rectal bleeding that he thought was hemorrhoids. And, it wasn't. It was actually bowel cancer. Hemorrhoids are common, and a bit of blood on the toilet paper is actually quite common. And Australians in particular are very quick to write that off as, oh, I think this is just fresh red blood, so therefore it must be hemorrhoids. That's not the case. That's not the case at all. It simply means that the bleeding is probably coming from somewhere near the outlet, but it's not diagnostic. It doesn't mean it is hemorrhoids. It just means it could be, but it could be something else as well. And you should be seeking medical attention for any of those new symptoms. And importantly as well, participating in the bowel cancer screening program, which is free in Australia, and
I
only
know. So lucky we are.
we are, but only 40% of Australians participate. So
Mm,
60% don't. So, a lot of when I do talks and things like that, I often just remind people, that probably one of the biggest changes we can make to improving bowel cancer outcomes in Australia is just to get people to actually do the test, which is available and free to them.
yeah. Well, because we have, like everything, we have an attitude of it'll be right. It won't happen to me. So
She'll
anyway,
be,
but
she'll be right. She'll be
yeah,
right.
you're
Yeah.
right. Bowel cancer is a huge killer.
Yeah.
So, all right,
Yes.
so the causes, including
Mhm.
psychological reasons, lifestyle choices, another big question, because there's just no
Mhm.
one answer to any of
Yeah.
this, but sexual activity. I often wonder too, you'll probably cover this, as far as the anal muscle. I
Mm.
don't know what it was like back when I was young, whether or not it's more prevalent now, but are young people engaging in more anal sex, and does that loosen a muscle in a bad way?
Yeah, good question. I mean, to start by addressing that question, I think, yeah, if you look at studies, there is an increased rate of anoreceptive intercourse occurring in the community, and the bottom line, I was going to say, excuse the pun, is that it's actually very rare for anal sex to cause pelvic floor dysfunction. I mean, I've not seen a patient where I've sat down and said it's because of anal sex that you have these problems. Of course, sexually transmitted diseases, sure, that can
Mm,
occur, as it can occur in other forms of sexual intercourse. But in terms of actually injuring the anal sphincter muscle, it's very rare. It doesn't really happen. This is my field and I don't see it. So I think it's very uncommon. What is common, going back to what I referred to before, so the two most common, I mean, there's many causes. The two most common, though, if we just stick to what is common, would be about half of what I see as obstetric trauma. So and that's specifically vaginal delivery. So cesarean section is very, very uncommonly a cause of pelvic floor dysfunction. In those patients, there's often another cause of pelvic floor dysfunction, not specifically cesarean section itself or even being pregnant. So it's specifically vaginal delivery itself and the trauma and the tearing to that supportive tissue, and sometimes the anal sphincter as well.
Oh yeah, because that's a lot of pushing, isn't it? Like
so it's a lot of
heavy pushing.
pushing. And there's a lot of focus on the anal sphincter as and we know that's easy to measure. We can measure that, and that's simply a marker because the actual amount of trauma happening in the pelvis is much greater than just at the anal sphincter level. It's as I talked about before, it's a lot of the connective tissue supports higher up in the pelvis that can lead to dysfunction later on. So that's about half. But let's talk about what else is there, because there's a lot of other causes as well. So like I talked about before, there's people who have what we call defecatory dysfunction. So in other words, they're unable to effectively empty their bowels, and when doing so, they exert excessive pressure. This is a fascinating disorder and a complex disorder, and there's many aspects to it. And I would also argue it's very much a Western disorder as well. You've got a group of people who have this problem ever since childhood. When you talk to those people, they'll usually give you a clue. They'll say, I remember having trouble when I was at school. I remember my mum giving me laxatives, my mum giving me suppositories. I remember having to see the doctor because I had abdominal pain, or because I remember straining. They'll often tell you, and that can be related to some people who just never quite learned how to poo properly, and we don't really know why. But also, not everyone has a good childhood. And in these important years when we're developing that reflex, because it is a reflex, it can be upset, as I referred to before, by psychological distress. About 15% of our patients will tell us about a history of childhood sexual abuse, which unfortunately is actually consistent with the Australian rate of sexual abuse. So this is very common. And it's not uncommon that in one of these consultations, it'll be the first time someone has brought this up or spoken to a doctor about it. And importantly, the first time that they have had that experience when they were a child, say 8 or 9 years old or whatever, linked to their symptoms that they got now that they're 60 or 70, say. And that can be, I often have to pull out the tissue paper during some of these consultations. May not be sexual abuse, maybe psychological abuse, maybe emotional abuse, or just a difficult or something terrible that happened to them. Their parents divorced and they got a lot of stress, or someone died, or just a traumatic event. And that can be something that occurred during childhood, but it can also be something that occurs during adulthood as well. And so, you hear these kind of stories.
So, Chris, are you saying then that because of the abuse psychologically, there just becomes a holding of those muscles?
Holding pattern. So they protect themselves subconsciously.
Yeah.
They're not necessarily aware of it. They're often not. Literally yesterday, I was talking to a young, lovely girl who, you wouldn't have guessed there was any problem. And I just started talking a bit about the possibilities of what could happen. And she said, can you please get me the tissue paper? And she just started bawling. And she told me about the emotional abuse that she had from her mother. And she told me how she always had migraines. She said she used to go to bed with a headache and wake up with a headache, and that she saw a physio when she was about 12, and the physio said that her whole body was tense, and he was trying to massage her, and he said she was the most tense person he had seen. And that tension can manifest as well subconsciously in that protective part of our body, the very muscles that are also involved with controlling your bowels and controlling your bladder. And so that you may not be aware at the time, but over years and years, that becomes your normal way of going to the toilet. And you pay the price for that years and years later when that pressure has led to trouble. So it's a fascinating disorder. It's not just that, it's also occupational, for example. So people who have really stressful jobs, people who are in shift work. The other day I was talking to a guy, he's a skipper on a boat. So he goes out on these long boat rides on super yachts and things like that, and they're constantly holding on and deferring going to the toilet. I can't go to the toilet because I'm too busy, because I've got to do this or I've got to do that. And then they'll tell you how they go to the toilet in the morning and it takes them 5 seconds because they basically push like crazy. or people who work down in the mines, or
Oh,
people
yeah,
in
of course.
construction where there's no toilets. So lack of availability of toilets. It's really fast. You hear to take a good history in this game, you have to listen to someone's whole life story. And it may be their occupation, it may be social aspects, it may be childhood aspects or experiences that they've had. It sometimes can be something like they had a terrible car accident when they were a teenager. They got smashed up, their pelvis was broken, their spine was broken, and they were stuck in hospital. And that affected, acutely affected the way all those muscles worked. They may have injured their back or have chronic back pain, and they're constantly holding on and protecting themselves and their paraspinal muscles. That can affect things as well.
Wow.
So it can be related to surgery. So you've got to have a really open mind, and all of these things contribute to defecatory dysfunction. And then there's people who say had surgery on their anus. So they might have had a terrible problem like an anal fistula or an anal fissure, which is a tear in the anus, or some other kind of bowel surgery, for example, or they got bowel cancer, for example, and they had part of their rectum removed. And that when you remove someone's rectum, I always say to patients that I do that on, this is going to affect your bowels forever, and you're never quite going to toilet the same way, because I'm taking away that beautiful reservoir and all its connections to your brain that you were born with, and now you've got something different, and it'll be okay, but it won't be quite normal. And so there's all these factors, medications. So some people excess coffee, so the coffee craze people. Some people drink massive amounts of coffee, or they drink. They have a huge amount of artificial sweetener, so they drink a huge amount of diet drinks, or they add a lot of artificial sweetener to their coffee or tea. Artificial sweetener has sorbitol in it. It's a sweetener, but it also goes right through you, and can actually lead to fecal incontinence of its own accord. So all of these
Wow.
things you have to think
Okay.
about. Yeah.
Oh my gosh, that's fascinating. Oh, I hope everybody's going to be listening to this. That's incredible. One cup of coffee a day is okay.
One cup. Yeah, we're all entitled to our coffee a day. I'm more
Everything in
referring to
moderation.
everything in moderation. You do get the odd people who they just become total addicts, and just by sometimes simple things like reducing coffee or addressing these simple things can make a huge difference. Yeah.
Yeah. And as far as, we were talking earlier about how often you actually go to the toilet to empty your bowels, what
Mm.
is normal? Because I know you don't have to go every day. A lot of people think you do. What's what's
Yeah. Oh,
okay?
look, it's funny you say that. So if you picked up any medical textbook, it will say that normal is about 3 times a week to 3 times a day. From experience and being in this field and listening to patients, I would actually say the opposite. I'd actually say going once a day is actually more normal, and outside that is less normal. If someone's going 3-4 times a day, what I usually would say is they're probably not going very well, or they wouldn't need to go so many times. Some people who go only to once or twice a week, it may be okay for them for a period of time, but after a few years or a few decades, they may end up running into trouble and end up needing to see someone like us at Queensland Pelvic Floor. So I'm actually, the more experienced I've become, the more I think once a day is normal.
Yeah. And so with for women who haven't delivered
Yes.
babies or haven't had babies, if they're getting prolapse or
Yes.
or incontinence, what would be the
Yes.
causes of that? Like
Same as
I
in
know
men.
people no exercise, they're not gym junkies,
No.
nothing.
So definitely, so same as in men. So the most likely cause is excess pressures. So you've got to try to think about all the things that I just talked about before. What in their life has led to them pushing so hard or generating so much pressure that they've put their organs under such pressure that they're now displaced and coming out of them, or internally prolapsing. A small percentage of patients may have what we call a connective tissue disorder, and the most common of those is Ehlers-Danlos syndrome, but there are others. Those patients genetically may be more likely to develop prolapse, more likely to develop hernias, for example, because their what we call collagen, or their connective tissue is more stretchy or weaker than others. There is a variation amongst people in terms of how good our collagen is. There's different types, but it's very unlikely that will occur without the pressure that accompanies it. Is it occurred because most likely defecatory dysfunction, they're straining too much, maybe not now, but maybe earlier in their life, or an occupational thing that I talked about before, heavy lifting, manual labor, all of these kind of things that are
And
day-to-day.
long-term standing.
Long-term, yeah, that's right.
Yes,
Gravity is
because
down.
now that I think of it, the person I'm thinking of, she was a hairdresser. They stand all day long,
Yes,
and if they're very
yes,
busy, they can hold their bladder all day as well. So,
yes,
yeah,
yeah.
okay, it's coming together now. I get it.
Yeah. There's always, sometimes it takes a bit of time. It's not till towards the end of the consultation, you'll suddenly, that'll be your light bulb moment, and you'll go, that they'll tell you the key thing that sort of unlocks it all. So yeah, it's not always immediately apparent.
Yeah. And so, as far as preventing it, I
Mm.
guess, well, a lot of the times we've sort of talked about things that have happened over the lifetime. So, there's
Mm.
no real way of preventing it now that we are already older.
Yeah,
But we,
yeah.
we can make it worse, like you say, with the amount of coffee, straining, having
Yeah.
artificial sweetener, anything else. Like, what about alcohol? Because I noticed, alcohol is a muscle relaxant, and I noticed I can actually get some leakage if I've had too many glasses of wine in a night. So,
Yeah, no,
I,
that's
I,
quite common.
yeah.
That is quite common. We do see those people. So alcohol in itself certainly can lead to patients having urgency. Often they'll tell you it comes on after a big night. I had a big night. Interestingly, also you'll get the patients who say their hemorrhoids flare after a
Hmm.
big night on the alcohol. So in general, I just advise what everyone would say, which is just to sort of drink in moderation. In Australia, the current guidelines are 10 units, if you understand units of alcohol per week. And so you do find the odd patient where clearly their symptoms are related to having a big night on the grog, and sometimes some advice about that, explaining it, and some adjustments can make a difference. So that is a component. Yeah. Yeah.
Okay, so that's, as far as preventing, once we get to 50 and beyond,
One of the other
just the
things,
way we sit on the toilet and what have you, I imagine.
yeah, so toileting technique is a big part, and toileting technique is what our specialist pelvic floor physiotherapists really aim to optimize, and they do much more than that. That they look at the entire whole lifestyle way you go about going to the toilet, when you go to the toilet, how you build it into your day, and then stool consistency is very important as well. So if you're passing small hard rocks, what we call Bristol type 1 stool, so those small hard rocks, the best rectum in the world is going to struggle with them to get them out, because you just got to generate so much pressure to get them out. At the same time, if your stool is always liquid, it's going to be harder to hold on. So what we're aiming for is a fairly bulked but completely soft stool that is therefore more easy to pass. And one of the ways that anyone can achieve that, or at least help, is fiber supplementation. So having plenty of mainly soluble fiber in the diet, and then potentially adding a supplement. And the most simple things that are common in Australia would be psyllium husks. They're fairly easy to obtain. It's easy to buy in a chemist. The brands include Metamucil and Benefiber. These are cheap. They can come in capsule form. They come in sachet form. And what I often say to patients is, if everyone in the world had psyllium husks every day, I would have less work. And so these are simple things and you might just need to take a teaspoon or two twice a day of psyllium husk, have a high fiber diet, healthy eating, and sometimes seeing a specialist pelvic floor physiotherapist if you have any trouble, for some pointers on how to go about going to the toilet, can make a big difference. So the physiotherapists, they really try to restore normal. So you may think what you're doing is right, but there may be things that can be done to make it a more coordinated and a less pressure inducing maneuver. And
Yeah.
that's really what they do. And they can make a huge difference. Virtually all of our patients that we see are referred to a specialist physiotherapist. And to be honest, the majority of patients, that's all they need. They don't need really to see a specialist surgeon like me. They certainly, majority, don't need surgery. We reserve that for patients where we've really maximized all of those simple things and the patient is still significantly bothered and troubled. Then we may consider it.
Yeah,
Yeah.
I would never have thought, like I've realized that in doing the research now, I wouldn't have thought of seeing a physiotherapist about the pelvic floor issue, but that
Yeah.
makes perfect sense. And I think I read somewhere that with proper pelvic floor exercises, you can, you know, solve about 85% of your pelvic floor
Yeah.
issues.
That's like I say, that's absolutely right. So physiotherapist, dietitian. We also have a very excellent dietitian at our center. So a dietitian who understands these disorders and basic advice that we've talked about is all that the majority of patients need. What's important to just to jump in there to talk a bit about pelvic floor exercises
Hmm.
is that a lot of the time when I see a patient, I'll say, look, I think, you would benefit from seeing a pelvic floor physiotherapist. And a lot of them say, oh, no, I know how to do my exercises. And what's very important to understand there is actually not exercises that that the physiotherapist will do. It's about restoring that normal coordination. And a lot of that is actually the opposite of exercises. It's actually teaching patients to relax and open their anus. And a lot of that involves relaxation of the pelvic floor. Sometimes the problem is actually that someone's pelvic floor is too tight or too strong. And
Mm.
sometimes those patients might say to you, well, I've been doing my pelvic floor exercises every day for the last 20 years. And I say, yes, I know that's the problem. That's the problem. We actually need you now to learn how to bulge your abdomen and how to let those muscles let go so that you can actually go to the toilet. So these physiotherapists are highly trained, real experts. They've all undergone further training in pelvic floor physiotherapy, and then on top of that, further training in defecatory physiotherapy to be able to give really top-notch advice. And often patients will come back to me amazed, just saying, I can't believe that I was doing it wrong all these years, and all I
Mm.
needed to do was see this physiotherapist, and I already feel a whole lot better in my whole self for being able to toilet better. So
Yeah, because the focus has been on making a strong pelvic floor rather than a
exactly.
healthy pelvic floor. So there is a difference,
Yes.
and doing it wrong as well, because I think most of us seem to get a misunderstanding about how the kegels work, but we're um, what is it? Pull up, don't push out. We're pushing
Yes.
out instead of pulling up. So,
Well,
uh,
yeah, Kegels are very effective. I don't want to do away with that. Kegels are very effective if you've just had a baby. So post-obstetric, absolutely, that is the right thing to do. It's about recovering from the trauma of vaginal delivery and recruiting those muscles and getting them strong again. But we're talking about something quite different. We're
mm,
talking about patients who are having trouble at another time in their life where Kegels may not be the right thing to do necessarily. It may be, but it may not be equally. So it's important to be assessed and have that understood.
yeah.
Yeah.
So, at what point does surgical intervention get considered as your only option? Because that's always a last call, isn't it? Going under a
Yeah,
knife.
look, the only time that surgery would be the only option is in someone who has an absolutely overt indication. So, for example, very occasionally someone will come to me with just a frank rectal prolapse. So their rectum's hanging outside their anus. Most of the time, it's incredibly distressing. It's leaking. It's bleeding. That patient needs surgery. There's nothing else that's gonna help them. Equally, someone with an advanced severe vaginal prolapse, that would be someone where it may be that that surgery is in their best interest to have up front. Everyone else, surgery is reserved for patients who have significant troubling symptoms, having absolutely maximized and failed all what we call non-operative therapies. Even then, it's never their only option. What I say to patients is, you have to buy the operation off me. I'm not going to sell it to you. There are things I can do, but everything has pros and cons. I'm a surgeon, so that's what I do, but everything I do has some degree of risk because it involves an anesthetic, a general anesthetic usually, and doing something to you. I don't offer patients surgery unless I think it's highly likely. I can look them in the eye and I think it's highly likely that I'm going to give them something that they're looking for, an improvement in the way they can go to the toilet, an improvement in their leakage or their incontinence. And there's things that we can do that are fairly low risk, and then there's more invasive procedures, and it's a balance. So the patient's ultimately got to decide, how troubled am I with these symptoms, and am I prepared to take the risk of surgery for the chance that it makes me better? And it's not guaranteed, because really the barometer of success is how someone feels. And so, we can't guarantee that. But certainly you can have amazing results when you choose the right procedure for the right patient at the right time. We've had patients crying and hugging us because they're so happy that they're not incontinent anymore, and that's very, very satisfying. But it's all about that. That's, I think, why we need that multidisciplinary center. We have a multidisciplinary meeting where we will discuss some cases where, we want all of us in one room, and we have the physios and the dietitian, and we have the urogynecologist and the gastroenterologist and the surgeon, the colorectal surgeon, and we all brainstorm about what might be best or what other options there are for that patient to make their life better. So it's all about picking the right time, and there's always options.
Wow, that's really exciting. I'm so excited that I'm in Brisbane and near you. So if I ever do have terrible pelvic floor issues, I'll be jumping in there. So,
Happy
and
to
what
help.
about if people are heading down the surgery track, how can they manage pain? Well, even without surgery, is there pain associated with pelvic floor dysfunction?
Yeah, I'm glad you mentioned that, because something I haven't mentioned yet, which is another factor, is pain, and in particular, it's worth mentioning endometriosis. Endometriosis is common, very common. 10%
Is
of
that a pelvic
females.
floor issue?
Well, it's related to pelvic floor
Okay.
issues. Yeah. So having endometriosis is associated with pain, painful periods, sometimes severe debilitating pain. And that pain, as you know, can go on for years and years. Many of these patients have pain for years and years before they're even diagnosed with endometriosis. And that constant monthly pain, and what we call chronic pain or ongoing pain, can sensitize the pelvis. And you can see a gynecologist, and an endometriosis expert. You can have endometriosis surgery, have it all excised successfully, but not be perfect afterwards. You may well be a lot better. Sure, your pain is a lot better. It's very effective surgery, but you may be left, unfortunately, with the consequences of those years of pain and sensitization. You may be left with ongoing pain. You may be left with sensitivity in your bowel, which can lead to dysfunction later on as well. Sometimes patients can develop sensitivity and pain in their pelvis that's perhaps driven as well by PTSD, anxiety, psychological distress. Sometimes they may have had some pathology in their pelvis. They may have needed surgery. They may have had some horrible infection. They may be having recurrent tears in their anus or fissures, which are very painful. Or they may be having recurrent hemorrhoidal crises, which can be also painful. And sometimes these things can set up for persisting pain. There are things these are difficult. There are difficult problems. There are things that can be done. However, our specialist physiotherapists can try to take away the hypertonicity, the spasm in the muscles with internal massage that is associated with this pain, and sort of down ramp pain that way. We can improve pain by improving bowel emptying. Sometimes we use special suppositories or creams that can help as well. And sometimes we involve a chronic pain specialist, so that there are actually specialists who only deal with chronic pain and may even have an interest in pelvic pain. And there's a number of interventions, nerve blocks, infusions, all kinds of various things that can be done to improve pain, medications. It is complex, but again, there's the whole area is complex, and it's about understanding the complexity, which is part of its fascination. And there's always things that you can do to make a big difference to people with pain as well. In terms of pain after surgery, I mean, that's more straightforward, to be honest. I mean, surgery, you know, I always say to patients, look, there will be some pain. It's not going to be a painless surgery, but you know, we have specialist anesthetists and painkillers and all kinds of ways you can press a button and it gives you a shot of morphine or patches, medications. There's all kinds of ways we can manage that. That's easier. It's more the persisting pain that's more difficult.
Yeah. And I mean, even then, medications, I mean, overuse of medications can have all sorts of other issues as well associated with them, can't they? So, yeah, if you can get the pain under control any other way. I've just never lived with pain myself, so I just can only imagine what it's like for people. So
I feel sorry for them.
Yeah, definitely. So long-term outcomes of treatment for pelvic floor dysfunction. What kind of follow-up care is typically required?
Yeah, really important question. Thanks for that. So look, what I say is that, you know, whatever we do in your pelvis to try to improve things, it's not, we don't really have a way currently of putting everything back how it was when you were 10 or when you were 20 or when, you know, you were much younger. Everything we do is just using what we have. None of it's perfect. It's likely that there may still be some symptoms, maybe, that we need to manage. And it's important to set expectations right about what a patient is likely to experience. So many patients, the vast majority who have the right surgery at the right time, do experience a significant benefit and improvement. But over time and over years and years and years, slowly, that benefit may wane. And it is likely over time, particularly if that patient goes back to straining, pushing hard, having hard stool, not complying with the other treatment, that their problem may return earlier. But there is what I don't like the word fix or the word cure, because I don't believe that's what we do. This is a chronic disease, and we make quality of life better with surgery, and we try to make that benefit last as long as possible with all the things that we do, but it's not a cure and it won't last forever. We have a research unit in the public hospital that I work in Brisbane, QE2 hospital, and we actually, everyone we operate on, we actually bring back every year, and we get them to fill out a whole bunch of questionnaires relating to quality of life and symptoms so that we can plot over time what actually happens. Some of our patients we've now been following for 10 years. And so, you know, I can tell you that, you know, the majority of patients remain better than they were before the surgery, but you can see the odd person getting a problem come back over time. And so it's important to explain that absolutely beforehand, that this is likely to happen over a long period of time.
Yeah. And when you sort of ask them, well, what have you been doing? So they might have been straining and doing all those things. But people have a habit of not telling the truth about what they've been doing. Sometimes, you know, no matter what age we are, we don't want to get into trouble for being naughty and doing the wrong thing.
Sure. You know, it's hard. Everyone's got to get on with their life and do what they got to do, and it's hard to keep on top of everything. So you know, get to all the appointments, and always remember to take your medication. It's hard.
Yeah.
We know it's a real life world that we live in, and we understand that.
Yeah. So what can clients expect from a consultation, if you can even get them in there? I imagine there's a lot of people that still even don't go and see anyone about it, particularly if it's not too bad yet, because they're embarrassed to talk about it.
Yeah, I mean, that's why I'm pleased to be doing this talk with you. And, you know, we are trying to get the word out there that A, it's common, B, you're not alone, C, there are actually things that can be done. There are people who are interested, there are people who care, and there are people who can make a difference to your life. So, with our clinic at Queensland Pelvic Floor, we have a number of ways it can be done, but most patients will start by seeing our nurse practitioner. So we have a nurse practitioner who's been in this field for many, many years. She's very experienced, and people love seeing her. And she'll have a chat with you, take a history, do a few basic tests to start with. It may be related to your bladder, maybe related to your bowel or prolapse, and then start some initial, what we talked about before, some basic advice. Might be fiber, might be some medication, might be some lifestyle changes, maybe involve a pelvic floor physiotherapist most of the time, maybe involve a dietitian, and then follow up, and potentially, maybe involve a specialist as well if needed. Some patients prefer to see a specialist first, and we're very happy to do that. And most of the patients I see, I talk about all of these basic things, and we start off on a path of non-operative therapy, and as I say, the majority of them get better that way. It's all about, we try to keep it all in one house, and so that you come in and you get treated, and you'll be followed up, and then it's a chronic disease. It's not like a one-stop shop. It's not like taking your gallbladder out. You come in, you have a gallbladder problem, we take it out, you're good. You don't need follow-up. These patients all need to be followed up, and that's what we understand that, and that's what we're about.
Wow. Do you know if you're the only multidisciplinary centre that is around?
As far as we know, we're the only centre in Brisbane in providing this level of multidisciplinary care. We started off by setting up a service in public. That was about 10 years ago at QB2 Hospital, and we could see we were just flooded with referrals, because people could see that it was what this group of patients need, and then we wanted to do the same thing for our private patients as well. And so we hope that the model grows. I think it's difficult to do and to set up, but it's actually what people need.
Yeah, absolutely. I agree. It's wonderful, just wonderful. Well, Chris, that has just been so informative. I'm sure everyone's going to get a lot out of it. And like you say, there is more talk about this whole subject now. So it's becoming really common and less embarrassing to talk about, and not a sexy topic, but an interesting topic. So before we say goodbye, is there just one piece of advice you would give to someone who's experiencing pelvic floor dysfunction?
You're not alone, and there are people out there who can help you, and there are things that can be done. I'm sure there are things that can be done that are going to make your life better.